Welcome everyone to the October Dutch webinar. I'm Noah Reed, Vice President of Sales and Marketing for Precision Analytical, creators of the Dutch test. Today we are delighted to bring you a very special guest, Dr. Tara Scott, to speak with you during Breast Cancer Awareness Month. Dr. Scott will explain breast cancer from an integrative medicine approach, diving into estrogen detoxification and the impact of endogenous and exogenous hormones. If you're new to us today and not already familiar with the Dutch test, Dutch stands for Dried Urine Test for Comprehensive Hormones. It is a group of validated tests that provide the most complete evaluation of sex and adrenal hormones, including metabolites. This simple and convenient at-home collection for patients and support on every comprehensive report from a team of hormone experts puts you in the driver's seat to helping solve your patient's most complex hormone issues. Registering as a Dutch provider is easy. If you sign up today, you'll receive 50% off up to your first 5 kits, plus free clinical consults, video tutorials, patient referrals, and expert hormone education. To sign up, just click the link that we've posted in the chat and complete the Become a Provider form on our website. I'm also happy to announce that the first episode of Season 2 of the Dutch podcast is now available wherever you get podcasts. This season, Dutch Chief Medical Officer Dr. Jacqueline Smeaton hosts the show with several new guests, including Dr. Joe Pizzorno, Dr. Will Cole, and many more. Follow the Dutch podcast on your favorite streaming app and sign up for updates from us by visiting the link in the chat. Now, a few housekeeping notes before we get started. You can find today's slides in the handout section of the control panel on your screen. This webinar is being recorded, and everyone who registered will receive the recording via email tomorrow. If you have questions, add them to the questions section of the control panel as well. We will conduct a short Q&A after the presentation. Lastly, keep in mind that the contents of this webinar are for educational and informational purposes only. The information is not to be interpreted as or mistaken for clinical advice. Please consult a medical professional or healthcare provider for medical advice, diagnosis, or treatment. Patients can find a Dutch provider in your area on our website by clicking Find a Provider at the top of the page. And now let me turn it over to Mark Newman, President and Founder of Precision Analytical, creators of the Dutch test, to introduce today's speaker. Mark?
Hey, thanks, Noah. Excited today, great topic, and one of my favorite providers, Dr. Tara Scott. I think one of the things that makes her one of my favorite providers is I love the dialogue that we get to have with providers, but I particularly appreciate the ones that I'm continuously learning from as we bat topics back and forth. I think Dr. Scott's got a great balance of digging into the literature, which is where I tend to stay most of the time. So I have to make sure I keep my head up and my ears listening as a chemist to people who have that application part of it as well in terms of what the research says, but also that very important, like practical, pragmatic part of just dealing with patients every day and what's working and what's not working in her practice. And so I'm excited to have her here, and I'll read her official bio to make sure I don't leave something out in terms of what's relevant about her credentials. Dr. Tara Scott first became involved with hormones and integrative medicine while practicing as an OBGYN and has been certified by the American Academy of Anti-Aging Medicine. She founded her practice, Revitalize, with a devotion to evidence-based regenerative medicine and a focus on hormone-related issues. She's also the creator of the online Revitalize Academy, a course that strives to help patients improve their hormone problems themselves. Dr. Scott has been speaking and educating for over 10 years and has taught doctors her clinical approach in 5 continents. So not Antarctica. Which other one have you yet to educate on?
I've done South America, Australia, Europe.
No Africa?
Yeah, no Africa yet. Yeah.
All right, we'll have to get there. She was chosen to speak for TEDx and has been featured in The List, Authority Magazine, Thrive Global, and on numerous podcasts, including ours. So if you haven't seen her episode from episode 1 of the Dutch podcast, you can go back and watch that there. So Dr. Tara Scott, the hormone guru, welcome to the show.
Thank you. Thanks for having me. So I will see if I can you guys see my screen now? We good? Okay. All right. So as Mark said, it is Breast Cancer Awareness Month. I do have pink on. It's not quite as pink as in the podcast, but it's a special topic to me because I really feel like we could be doing a better job. Now I'm trying to find where I can click forward. Okay, so what am I going to cover today? So I'm going to talk specifically about the hormones, the female hormones as it pertains to breast cancer. And then I'm going to give you my version of how I like to measure estrogen and decide what I call the estrogen load. And then we're going to go over estrogen metabolism, which is super important. And then we'll talk about the evidence about hormone therapy and cancer. So as Mark said, I got my start as an OBGYN and then went on after I saw the light and, came to the bright side. And I've been doing only functional integrative medicine now. And so I've been in practice about 30 years. One of the reasons why I'm super interested in breast cancer is, of course, my own messed up hormones. That's what led me down to this field after my struggle with infertility. But what I found out is that genetically, I don't detox very well. I've got actually 3 out of 4 MTHFR SNPs, which is not, according to Dr. Ben Lynch, not that common. And I've got a slower upregulation of 1B1, which we'll talk about, and COMT. So I've got my antenna up to make sure that everything is balanced with me. But for sure, it's the patients. It's the patients that are affected that really makes me want to spread awareness. And I always, dedicate any talk to my friend Laura, who passed away after a 2-year struggle with breast cancer. She was actually diagnosed right after she had her son. And she was in her early 30s and really fought a lot. And she and I partnered together and did several events promoting awareness about breast cancer. And she just was tireless about doing that. So I want to continue her legacy to be able to educate patients and providers as well. So we all know that there is some link with hormones and breast cancer, and the incidence of breast cancer, as pictured here on the orange line, really starts to take an upslope in the perimenopause. So if we map that against your hormones, you can see that's about the time where progesterone drops and you start having really erratic estrogen production. So clearly there's a link between those hormones. So we can look at the statistics of estrogen metabolism, and we can look at specifically of breast cancer, and hormones are listed as a risk factor, but it seems like, at least in my practice, maybe it's that I'm getting older, but I'm seeing breast cancer actually being diagnosed earlier and earlier. And so it's the statistics of that premenopausal breast cancer patient that I really have a heart to kind of decrease that incidence and shift from early detection really to prevention. The known risk factors of breast cancer, we all know it increases as you age. We have much more than the BRCA1 and 2 gene mutations. We have a whole panel now, CHEK2, RAD50. And so those are generally tumor suppressor genes. And what that means is you normally have a gene that will turn off the growth of cancer, and you lack that, so then you have an increased risk of cancers. Family history, but really only 1 in 8 ladies will have a family history. So it could be your reproductive history, usually those with early menarche, late menopause, any kind of radiation. And I've put in there elevated endogenous estrogen levels. I just did a deep dive in the literature, and we'll touch on that here, that there are some studies that link endogenous levels in premenopause and perimenopause to an increased breast cancer risk. And then there's that conundrum of, does hormone therapy increase the risk? So we'll go over that as well. And obesity and alcohol are 2 other risk factors that everyone can agree on. So what actually is cancer? Cancer is unregulated cell growth. And some people think every one of us have some kind of cancer, but our immune system does the job of getting rid of it. And we remember that cell cycle. If you have unregulated growth and proliferation, the cell is supposed to commit suicide, actually, and that's supposed to take care of it. For some reason with cancers, you don't have that mechanism. It's not turned off, and you have continued rapid dividing of the cells. And so this healthy cell usually uses oxygen and glucose and produces ATP, but the cancer cell is anaerobic and siphons off the glucose and gets that energy. So most people actually die, a lot of cancer patients die of malnutrition. Sometimes it is from the cancer pressing and involving on vital organs, but a lot of times it's just nutritional issues. So one of my favorite slides here is the menstrual cycle. And so we know that, I'm sure you guys have learned about this, but just as a quick review, we like to divide it into basically three basic sections. The first being the follicular phase. The whole purpose is to get the egg ready for ovulation. So you can see that estrogen is higher and there's usually not a lot of progesterone produced. The middle 2 days is the ovulation spike. You have the FSH and LH that goes up, the release of the follicle. And the second half of the cycle, or the third, depending on how you look at it, is the luteal phase, where the body prepares for pregnancy. So this whole purpose is to get ready to see if there is conception, get ready for implantation. After ovulation, the remainder of the follicle does invaginate and form the corpus luteum, where its function is to produce progesterone until the placenta can take over. So if we think about the steroidogenic pathway, one hormone does not involve the other. Everything's interconnected. All these enzymes are genetically coded, so they can all affect how everything, you can give one hormone and not affect the other. They're all interconnected. So if any of you out there are OBGYNs, you will recognize this textbook. So it's Clinical Gynecological Endocrinology and Infertility by Dr. Leon Spiroff. It was our Bible when I was a resident. So we had to learn all of our physiology from this. So what's in this book, I believe to be true. So Dr. Spiroff says that estrogen causes proliferation. He also says that progesterone inhibits this proliferation, causes a decline in DNA synthesis, interferes with the estrogen receptor. Estrogen may stimulate many oncogenes that mediate estrogen-induced growth. So we know this to be true with endometrial cancer, and we think it to be true with breast as well. But he says here on page 624 at the bottom that the breast and the endometrial cells are similar. So when we think about estrogen, I always think about Sofia Vergara. Look at her beautiful hair, her luscious hair and her curves. We know estrogen promotes growth, body development. We know it slows bone loss. And basically there's three types of estrogen. There's estradiol, which we know is good for your bones, good for your heart. There's estriol, which is a weak end metabolite. It's good for your skin, we know, and it's really not produced in that much quantity except for when you're pregnant. And then we have estrone, which I think could be the bad one. We did hear last week at the annual meeting of NAMS about estatritol, or E4, which is a rare estrogen only produced in the fetal placental component when you're pregnant, only during that short time, and that it is inert metabolite. So more data coming out about estatritol, but right now we don't know much about E4. So we know these three have different origins. For example, estrone is the highest quantity in menopause. You can have your ovaries removed and still be able to manufacture estrone because it comes from androstenedione and it's made by aromatase in the peripheral tissue. Estradiol, 95% of estradiol is coming from that developing follicle during reproductive cycles. And estriol, as I mentioned, is an end metabolite from either estradiol or estrone. So I like to think of estrogen as three sisters, right? They're all different. And anyone who's a parent knows that you can't really parent your kids equally. They all have different personalities, and one might motivate with positive, motivation. One might need more, negative consequences for behavior. So these are the three sisters of estrogen. You've got this one over here on the left. That's estradiol. She's popular. She's good at sports. She is, smart. She's got it all. And then on the far right, you have estriol. She's weak. Look at her hiding behind her sister. She does not exist unless she is broken down from estradiol and estrone. And then the middle would be estrone, I would say. And anyone who watched this show knows that she was kind of the bad one, right? So estrone isn't, I don't want to say that estrone is bad, but in the wrong environment, in the wrong quantity, because it stimulates growth, could be one that could promote cancer. So not all estrogens act the same. We have an alpha and a beta receptor in every cell of our body, including the breast. And we know that alpha causes proliferation or growth, and beta will do the opposite. I always think alpha accelerates, beta brakes. So this is a table that demonstrates the receptor affinity at the different alpha and beta receptors. This was in the Journal of Menopause. So you can see here that at the top we have estradiol, and it's equally agonizing the alpha and the beta receptor. And then we have estrone, which is weaker than estradiol, but you can see 60 receptor affinity for alpha and 37 for beta. So it preferentially will bind the alpha receptor with a 5-to-1 ratio. And then estriol, weaker of all, but still has a higher predisposition to bind the beta, so keeps things in check that way. The problem we run into now is that we have other sources of estrogen. We've got our environment, we've got our plastics, we've got our chemicals, we've got preservatives, and what, for any of you that are around my age, when we were growing up, or like high school 30 plus years ago, kids did not look like they do today. It's just different with all the environmental exposures. So what are the reasons why you would have high estrogen? Well, one of the main things that I missed being a traditionally trained doctor is the effect of estrogen metabolism. So I thought, well, maybe you just make a lot. That's just your genetic predisposition. Now I know it's definitely environment and diet. Also your genetics, as far as your genetic coding of the enzymes involved in estrogen metabolism. And the fourth way, which is one of my pet peeves, is it's iatrogenic. We still have standard of care after hysterectomy to dose estrogen only without a complementary progesterone. So I know that is the standard of care, and I am vehemently opposed to that. And I'll present the data why. So when we think about progesterone, it's going to balance out estrogen. It's going to protect against endometrial cancer, I believe breast cancer as well, fibrocystic breast, and it actually helps your thyroid work well. It promotes sleep and helps with memory. So we always think of testosterone as muscle mass, right? Libido, but it's also about stamina, bone mineral density, lean body mass, mood, memory, skin and hair as well. So women also need a proper amount of testosterone. And that can correlate with breast cancer risk as well. When we think about estrogen detoxification, it's 2 stages in the liver, phase 1 and phase 2. And you may have learned about this in med school. Phase 1 is cytochrome P450. In the case of estrogen, it's usually a hydroxylation. Then you have an intermediate metabolite. And then depending on what we're talking about, whether it's estrogen or some other compound, you have a conjugation pathway. And then it either goes down the slide into the stool or out the gallbladder or kidney to be excreted that way. So healthy estrogen metabolism needs many things. You need specific vitamins that are cofactors for those enzymes. You could affect it by a diet that will augment or induce phase 1 enzymes. You definitely need a healthy intestine, because after the liver detoxifies, where do you think that compound goes? Into the gut to be excreted. You need the minerals that are also cofactors. Other hormone abnormalities like insulin resistance can slow this down. And so it's all, like I said, a complicated web. So if we think about estrogen, do we think it's always bad, or it's, we shouldn't have any estrogen? I like to analogize it to water. I mean, all of us, even men, have estrogen that occurs naturally in your body. And I find it hard to think that anything that occurs naturally in your body can be harmful. So let's take the example of water. Suppose I tell all my patients to drink 2 liters of water, okay? And that no matter what, they are diehards and they follow my advice. But what if you are a marathon runner and you run a marathon at 80 degrees and you only stick to the 2 liters of water that I mentioned, right? Well, then you're probably going to get dehydrated. On the converse, what if you're a dialysis patient and you stick to the 2 liters of water? I could probably have caused heart failure for you. So I ask you, is the problem water, or is it the amount that was prescribed to the patient in these different clinical situations? That's how I think of estrogen. So I really missed the boat for I don't know how many years. Well, the first 7-ish years I was practicing traditionally, and then I started practicing, really concentrating on hormones, but I didn't know about estrogen metabolism until I finished my fellowship. So probably another 5 or 6 years I was prescribing estrogen and other compounds without checking about estrogen detoxification. So I think that is how there are some patients that I don't understand, like, why was this dose having this effect? Because you really need to consider the patient, not only the patient's age, do they have ovaries, do they not have ovaries, but the pharmacokinetics of what the body does to the drug and the pharmacodynamics of what the drug does to the body. So again, back to Dr. Spira, we can all agree that estrogen causes proliferation and progesterone inhibits it. So estrogen causes growth, progesterone causes apoptosis. So that has to be in balance. Estrogen also stimulates oncogenes and progesterone antagonizes this. So that you can see how the balance of these two is very important, even if you're not trying to conceive. So if we look at the steroidogenic pathways, we're going to concentrate on the lower right-hand side of estrogen metabolism. So if I hone in here, it looks like this. You've got estrone in the center, but you've got estradiol on the side. So both estradiol and estrone have the same pathways of estrogen metabolism. In between them, they have 17-beta-HSD, which is an enzyme that is reversible. So that means estrone can turn into estradiol and vice versa. One of the things that can happen is estrone can be sulfated by sulfonyluretransferase or sulfatase, and that's one way that it can get out of the body. Now, if we dive in deeper and look at it a little bit more simplified, it looks like this. You've got three pathways. That's phase one. You've got 1B1, 3A4, and 1A1. Those are all cytochrome P450. And we've labeled these as, I know Dr. Trinidadi calls them the good, bad, and the ugly. And then the phase two is COMT for both the 2-hydroxy and the 4-hydroxy, but the middle where you see the 16-hydroxy, that goes across to estriol. The problem is if you go straight down from estrone and you go to that 4-hydroxy and you don't go out to COMT, it can be a quinone, which can become carcinogenic. Now, you've still got a back door. You've got the GST, which is glutathione S-transferase, which can still neutralize that quinone. But if it doesn't get metabolized, then you're out of luck. So let's break it down. We have the good estrogens, they're weaker. They have a lower binding potential to the alpha receptor. So we think that the 2-hydroxy really is more anti-proliferative in the breast. And then we got the methoxy estrogens after it's been metabolized by COMT. And then we know that this also inhibits cell proliferation. So we've got, inhibiting growth from both of those. The bad is the 4-hydroxyquinone metabolites. They can be depurinated, and we've seen data that women at high risk for breast cancer had higher levels of this adducts in their urine, and that in some certain preparations of adenocarcinoma, there was a higher amount in that. The 16-hydroxy was initially labeled as, this is from 3A4, was labeled as bad, but now, if just skip to the last point, recent evidence drawn into question the significance of the 16-hydroxy in relation to breast cancer. This is the promoter of estriol, and this would be your yellow one here on the test, or sorry, it would be blue on your test. So it's actually easier for us to increase the 2-hydroxy pathway than it is to reduce the 4-hydroxy pathway. That's just the nature of the SNPs and how they are receptive to being induced. So one of the things we can do, we know that insecticides actually inhibit 1A1. That's not good. That's the green. So we want to minimize our environmental exposures. Resveratrol, lots of data about resveratrol lately too in the guise of endometriosis and breast cancer, which is exciting. And it actually inhibits peroxidase activity, so reduces the formation of catechol estrogen quinones. It also increases NDPH quinone reductase activity. So if you have a patient that has that high pi wedge of red, resveratrol is one of my favorite go-to treatments. The same with N-acetylcysteine. It also, the consumption of N-acetylcysteine for 1 month reduced urinary levels of estrogen adducts as well. So that's another option if you're going down that 1B pathway. Iodine is questionable, and it's not something that I give for estrogen detoxification, but it's something to kind of have an eye on and understand what is the effect on breast cancer. It's interesting that in Japan, where they have a lot of iodine in their diet, they actually have lower incidence of breast cancer. So there is a connection there. We just don't have it as a therapeutic option at this point. The interesting thing that's coming on the horizon now, it's funny because certain topics in traditional medicine, like monitoring hormones, is woo-woo. But now we can talk about the microbiome. We can talk about the gut. So there is some data. There were some lectures at NAMS last week on the gut-brain axis, so the vaginal microbiome. So it's okay to talk about the microbiome. Not okay to talk about estrogen monitoring yet. But anyway, so we know the gut is one of the phases involved in estrogen detoxification. Where do you think it goes after the liver? It goes into the gut to be excreted in the poop. So if you have a problem with your gut and you're not metabolism, or you have a high beta glucuronidase, you're going to recirculate that estrone right back into the gut. So calcium D-glucarate is a therapeutic option to help bind up that beta glucuronidase and getting the gut all healed as well. You want to work on that. So again, as I mentioned, we want to increase the function of 1A1. We'd like to increase COMT. Things that I would use to augment that are certain B vitamins, magnesium, sometimes SAMe. I don't always reach for the SAMe right away. We want to increase quinone reductase, and one of the things that I would do for that is resveratrol, and increase glutathione conjugation. That's where you might want to use NAC. Want to try to decrease 1B1, reduce peroxidase, and then also reduce beta-glucuronidase, and that's where the calcium D-glucarate comes in. So when we're talking about breast cancer specifically, which are the SNPs of estrogen detoxification that matter? Well, you know, it's not directly an estrogen detoxification pathway, but it's more of a peripheral. It's in the not the methionine cycle, but the folate cycle. MTHFR has been associated with an increased breast cancer risk. And the thing is, when you start looking into methylation, it's not just this enzyme. It's like, I don't know, 10 or 20 enzymes. I don't know if I have a slide on this, but it doesn't exist in isolation. So this is one of the puzzle pieces that could increase the risk. Looking specifically, the COMT is the one, COMT, that's phase 2 estrogen detoxification in the liver that I see most commonly associated. Now, when we think about COM, it's either reported as VAL-VAL or MET-MET or VAL-MET. It's not usually heterozygote or homozygote. It's supposed to be reported as VAL-MET. And it's 158 is the one. There's three that we have the most research on. One is 158, one is H62H, and the other one is -61. Those are the three SNPs and the alleles that we have the most data on. There's a lot of different alleles that may be reported in something like 23andMe. So the COMT, if you have for your neurotransmitters, VAL-VAL or MET-MET, it's significant, but not so much for the VAL-MET. But for hormones, I've seen VAL-MET, which is heterozygote, is significant in estrogen detoxification. Here's another SNP that I think matters for breast cancer. It's not related to estrogen detoxification, but it's related to the metabolism of tamoxifen if you are prescribed it. Tamoxifen is not the active metabolite. It has to be metabolized from 2D6 into endoxifen. If we looked at the receptor affinity of tamoxifen, it's not really the compound that has the action, it's endoxifen. 1B1 is another problem. That's phase 1. And SNPs of phase 1 are generally up regulations. So if you have a SNP, if you're heterozygote or homozygote, it means that is going to be induced to work more. And if you're driving things down that pathway to 4-hydroxy with a slow COMT, you're going to have a bottleneck there. Not a good combination. The other one that I don't see talked about as often is 19A1, which is aromatase. This was my friend Laura's problem, is she was dumping her testosterone into her estrone. And so it's definitely a problem that you're not going to see on blood work, maybe not even in urine, because this is happening in the periphery. So it's hard to detect. So when we're thinking about SNPs, there's a lot of things that affect the highways. It's like it's like a highway. It's like traffic. It could be the time of day. So in the upper right, you have rush hour, and on the lower right, you have construction. Either of those two things can affect your commute. So that's just like your estrogen detoxification enzymes, right? Your genetic coding could affect your enzymes, but also all these other chemicals, all these other compounds, and all these other foods can also affect it as well as stress. So you may have heard of the Goody mice experiment. I thought it was interesting in the sense that they started seeing these yellow mice that were fat, and they seemed to have problems with their blood pressure and obesity, and they knew it wasn't the fur that was causing the problem. So they fed these pregnant yellow mice methyl donors in their chow. And what they found out is the yellow pregnant mice gave birth to skinny brown mice. That is epigenetics. That is being able to change the genetic programming with that supplement. So when we talk about endogenous estrogens, let's talk a little bit about this. This was actually a study that showed, this was published recently, 2021, the high activity of CYP19, that's aromatase, may increase breast cancer risk by providing more estrogen for activation. Carriers of 1B1 were significantly more frequent around breast cancer. So significantly higher risk for breast cancer was MET, that's slow. That would be homozygote, and increased levels of estrogen quinone and depurinating addex when estrogen metabolism is unbalanced. So this was exciting to me that now I'm seeing it in print when, I'm getting like some shade on TikTok for even saying this kind of stuff from other providers because they're like, there's no such thing. But here is the data that says that yes, estrogen metabolites do have something to do with it, and estrogen detoxification. So if we look at a case, this is my friend Laura. She was 32 years old when she came. She was recently diagnosed with breast cancer. She had a boy and he was 6 months old. She was still nursing and she noticed that she had a lump. She did have a paternal aunt and a paternal grandmother with a history of breast cancer. When she was diagnosed, her tumor was already 2.5 centimeters, stage 2B, but it was triple negative. She was also tested for BRCA, which was negative. And so they started right away with chemo every 2 weeks, and they gave her Lupron just to shut her ovaries down. She came to me with some of these serum labs done already, and you can see that her thyroid looks okay, hemoglobin looks okay, vitamin D is good. Her ovaries indeed do look suppressed. All of her female hormones are really low. She wanted to do a Dutch test and look at her estrogen metabolism. And sometimes when you do this and your estrogen levels are really low, you may get a little bit of a skewed result because if you think about it, I have 3 kids. And if they only have $10 to spend, they might spend it differently than if they had $1,000, right? Your patterns of spending or your patterns of metabolism are going to be affected by the substrate. So if you have a lot of estrogen, I think we can accurately see, but be careful if you have really low levels. You might not see the problem with estrogen detoxification. So she did this after she was on Lupron. You can see her, even her estrogen, she was a thin girl, estradiol super low, lower than the postmenopausal range of untreated. But we can see here that she had a low activity of COMT. And the other thing that I did not like is that she had this really flat cortisol curve. And in my experience, when you have this flat cortisol curve with really any cancer, I know there's some data with breast cancer patients, it's not a good prognosis. So here's her genetic testing. MTHFR for 677, she was heterozygote. For 1298, she was wild type. And for COMT, she was MET. Okay, so slow. So another patient of mine was first diagnosed with breast cancer at age 31 in 2009. So she had a lumpectomy, chemo, and radiation. She had recurrence in the contralateral breast. So it's really unusual to have that. So she ended up having bilateral mastectomy and she was on tamoxifen. But I was worried because she continued to have heavy periods and hormonal symptoms. So I'm like, okay, great. We removed her breast. We've got her on tamoxifen, but what are we really doing to control her estrogen? So these are old labs, so it's kind of hard to see, but you can see in salivary testing, and this is 2012, she had a higher estrogen, lower progesterone. And this is another salivary assay on 2013. Just wanted to show you here, she's on tamoxifen. Tamoxifen does not block the production of estrogen. She still has very high estrone and very high estradiol while she is taking the tamoxifen. And again, look at her DHEA really low and her cortisol is not terrible, but just to tell you that the tamoxifen is a selective estrogen receptor modulator and it's not 100% blockage of that receptor. Here is an estrogen metabolism test that she did way back in 2014. This is all that was available, and you can see that she did have a higher amount of 4-hydroxyestrone and lower amounts of the phase 2 metabolites. Again, looking back at this chart from Lisa Boothby's chart, we can see that the receptor affinity for tamoxifen is much, much lower than estradiol or estrone. Again, we know that the active metabolite is endoxifen, but even just choosing between tamoxifen or raloxifene for a high-risk patient, I'm not talking about a breast cancer patient, you get a much higher receptor affinity for the raloxifene. So here's another saliva results, again, on my patient in 2016. So still really, really high estrogen levels. Here was a urine test that we did here. Here's the dried urine in 2019. You can see very high estrone, very high estradiol, and high estriol. And again, low phase 2 metabolites, while we're still seeing very low DHEA in her as well. Again, here's that cortisol I'm not really a fan of, but it's a really low cortisol curve as well. She's doing well right now, as far as I know. So we can see that there are 2 cases that we do see on testing the abnormalities that I'm saying exist. So the next question is, does hormone therapy contribute to breast cancer? Well, let's look at the data. It all started in 2002, and that is when the WHI headlines made it. And everyone still thinks if you polled, I'm sure if you polled 100 gynecologists, 90% would still say hormone therapy causes cancer, and that's part of our problem, right? That's the gynecologist. If you polled the family practice doctor, I'm sure it's like 99 to 100%. So let's look at the WHI. What did they actually look at? They looked at Premarin and Provera in 10,000 women. They actually had 8 more breast cancer, 8 more strokes, 7 more heart attacks, 18 more DVTs or PEs, but 6 less colon cancers, 6 less hip fractures, and 97% of the patients had no untoward events. And remember, these women were average age of 63. So I think the conclusion was wrong because older age, we're not starting hormones at 63. We'll be starting them closer to 50. There's a difference in age then. We know that early start is heart protective and brain protective. I don't use those hormone preparations in this study. I don't use CEE. I don't use MPA. Thirdly, oral versus transdermal have different risks as far as clotting. And then for breast cancer, there's a difference in risk between a progestin and progesterone. In JAMA in 2010, there was an analysis that said, okay, it's the progestin that causes the problem. And with using this combination, there's an increase in breast cancer mortality as well. So this was in a throwaway journal called OBGYN News, and this was in 2012. One side of the newspaper said estrogen cuts breast cancer. On the right side, estrogen increases breast cancer. So this is part of the confusion why even us as providers, unless you've made it your specialty, is very confusing what to do. The study on the left is Lancet Oncology in May of 2012. Guess what data is? WHI data. So this is not new data. It's 10 years old at this point. And they're calling the incidence of estrogen only cancer 0.27 and 0.35 a significant difference. I don't actually know if they said it was statistically different, but to me, the difference of 0.07% is not a big difference. But if you look on the right, the Nurses Health Study, which is observational, it's not placebo controlled, but they're saying you have a 22% increase with 10 to 15 years of estrogen only, and 43% increase with 15 to 19 years of estrogen only. So to me, that's also got 5 times more patients. That makes me worry more than the WHI, which said it's okay to use estrogen only. So this is an important study. It is before the WHI, but I always include this because this speaks to the histology. We've got breast biopsies being done in the follicular phase, so there's no way there's an endogenous progesterone protection, and they used estradiol gel on the breast, and then on some of the patients they used progesterone gel on the breast. And what they saw is that the histology did reflect that progesterone at the breast has a therapeutic value to prevent breast cell hyperplasia. So again, all these women that were giving estrogen only, we are causing proliferation without the balancing apoptosis, which worries me. In 2002, these are studies then that are speaking to the different preparations of hormones. No increased risk of breast cancer with micronized progesterone and transdermal estrogen. Oral micronized progesterone, contrarily to synthetic progestins, did not increase breast cancer risk with transdermal estradiol. 2005, progestins and progesterone. They're saying that a high endogenous testosterone in premenopausal women was associated with an increased risk of breast cancer, but preparations considered containing progesterone and not a synthetic progestin should be used for hormone therapy. This is a big study I like to quote a lot, 2005. It's not a randomized placebo-controlled trial, but it was an observational trial with a control group. They had 4 groups of women. One group took no hormones. The other group was estrogen only after hysterectomy. Then they have add estrogen with a progestin, and the 4th group was estrogen with progesterone. And initially, when they published this in 2005, they had 55,000 women, and they saw that there was actually a decrease in breast cancer with progesterone and an increase with progestins. They followed up with this, and now 80,000 women published in 2008, ages 40 to 64, so a more appropriate age range, followed for 8 years. And what they found is that breast cancer, there was an increased risk with estrogen only, but there was no increased risk for women who took estrogen plus micronized progesterone compared to the people who took no hormones. So I think this is an important study, although it's observational. So this is another study, if you haven't looked at it, by Dr. Holtorf that talks about the anti-apoptotic effects of progestins in contrast to the apoptosis from progesterone. So at the cellular level, they don't act the same in the breast. Here's another reference to unopposed estrogen causing an increased risk for breast cancer up to 23%. So again, it just boggles my mind that some of this is still iatrogenic. So this was a study more on the WHI data that said that there was an increased incidence of estrogen with progestins, but lower incidence of estrogen only. And again, look at it 2012, we're still recirculating the same data. This study in 2014, again, the E3 EPIC cohort that was a large observational trial, said that progestogens other than progesterone had a significant risk of breast cancer, even after you stopped it. Progesterone associated with lower breast cancer risk compared to progestins. Estradiol therapy in breast cancer patients. Now, this was a meta-analysis. 14 studies were looked at. And what they found is that the risk of breast cancer varies according to the type of progestin and how long you treat it. So in 2018, getting a little bit more current, estrogens, vaginal use do not increase the risk of breast cancer. Limited evidence that estrogens with oral micronized progesterone has a cancer, but of course we have large observational studies that have that data. This study I put in here because it talks about the endometrial cancer after breast cancer, and it emphasizes that the breast and uterus should be considered similar. In 2019, things got all shaken up again because the Lancet came up again and said, oh gosh, there's an increased risk of breast cancer. Everyone freaks out. And then if you look at it, then they have to publish this answer. The International Menopause Society and the British Medical Menopause Society said, that study really looked at older observational studies and formulations of hormone therapy that we no longer use. So these are studies that are from the 2022 position statement by the North American Menopause Society. Any of you guys know they put out a position statement. It was last in 2017. So after now 5 years, they've now released a new position statement. So basically what they say is the risk of breast cancer related to hormone therapy use is low. 1 additional case per hormone therapy, or 3 per 1,000 if you're using Prempro. That you should tell women that yes, you could get breast cancer, but it's a low risk. And we know that it's the type of hormone, the duration of use, the regimen, prior exposure, and your individual characteristics. And that different hormone therapy regimens can be associated with different breast density, which makes mammograms a little bit more difficult to interpret. So a preponderance of data does not show an additive effect of underlying breast cancer and hormone therapy. So that's what they say, level 2. Insufficient data is available to assess the risk of breast cancer with newer therapies, such as selective estrogen tissue like bazidoxifin. Other observational studies shows that hormone therapy do not increase the risk of breast cancer in actual BRCA patients. Systemic hormone therapy is not advised for breast cancer survivors, although hormone therapy may be used or considered if they have severe vasomotor symptoms that are not responsive. So that's also something you want to discuss with our oncologist. We prefer that they be at least 5 years out of diagnosis. For GSM, low dose vaginal estrogen therapy or DHEA vaginal can help, and regular breast cancer surveillance is advised for all patients that are postmenopausal. So this study just came out 2022. It was looking at vaginal hormone therapy in breast cancer patients. So basically what they said, in postmenopausal women treated for early stage estrogen receptor positive breast cancer, neither vaginal estrogen therapy or menopausal hormone therapy, which is systemic, were associated with an increased risk of recurrence. And this study, I think, was done, a Danish study. So this revealed that the risk of recurrence in patients receiving vaginal estrogen with aromatase inhibitors, there was a slight increased risk of recurrence, but not mortality. So I guess the question is, do hormone levels matter? I mean, should we test? I mean, that's what this dried urine test is all about, right? We're trying to see, should we be testing our high-risk patients with this dried urine test in perimenopause, in postmenopause? Should we be looking at this if they're also treated with hormone therapy? My opinion is yes. I think everybody with any estrogen-related pathology like endometriosis, fibroids, heavy periods, certainly breast cancer history, should have a dried urine test, the Dutch test. And I think every patient who is taking hormone therapy at some time after they've been on hormone therapy should have a Dutch test to evaluate their estrogen metabolism as well. So this is a study looking specifically about estrogen metabolites. Now, I want to clarify, this was done in 2010, and Mark can probably tell you better than me what year the assays changed. I think it was somewhere around 2015. So the older assays for these estrogen metabolites were not as accurate or good. So some of these studies, this is saying 3 prospective studies, didn't really see a huge there was only 3, they said, up to this point that evaluated estrogen, urinary estrogen metabolites and breast cancer risk in premenopausals. And they only had the 2-hydroxy and the 16-hydroxy, so not the 4-hydroxy. In the large EPIC cohort, they had a significant inverse relationship with breast cancer. So what that meant is that if progesterone was low, there was a higher risk of breast cancer. And the only consistent finding up to that point was that testosterone levels higher in premenopausal increased the risk. This was published in 2013, breast cancer risk in the Nurses' Health Study. They had 29,000 women, and they had early follicular and mid-luteal labs. So that's another problem, is that they don't always look at the right time. Luteal estradiol was associated, so if it was high, there was an increased risk of breast cancer. Luteal estrone was not, free estradiol was not, and progesterone was not, which it kind of surprised me that progesterone wasn't, but maybe it's not the progesterone, it's the estrogen that's the issue. So androgens were modestly increased the risk of breast cancer and stronger for the hormone positive. So premenopausal serum hormone, this is a study done in the Journal of Cancer in 2014. This was a case control, EPIC again, and this had 810 breast cancer patients, and they looked at serum estradiol, free estradiol, progesterone, testosterone, free testosterone, SHBG. So what they did see is that there was higher testosterone with an increased risk of developing breast cancer, and also possible estradiol for tumors before the age of 50. This study was done in 2002 and looked at 9 prospective studies on breast cancer. None were taking hormones. And what they saw in this study is that there was an increased risk with all concentrations of estradiol, free estradiol, sex hormone binding globulin, estrone, all of the hormones. So the increase in risk was associated with increased levels of all sex hormones, and after the subjects developed breast cancer within 2 years. This is the same study. The main finding was that they had high serum concentrations of sex hormone, twofold higher for the ones that had breast cancer, than did the postmenopausal women with low serum concentration. So levels of estrone and estrone sulfate were strongly associated with breast cancer risk. And in this, they said there was just one serum measurement. So in my practice, I have some people that I've been following for years, and you can extrapolate risk from that. So they're saying in this study, in the future, the measurement of endogenous hormone levels might help identify women who are at increased for breast cancer. That's what I'm trying to say, is we should be testing people. Another study on testing published in 2021, endogenous estradiol and leptin. And so what they found is circulating estradiol played an important role of breast cancer etiology, even with low estrogen nations. Adipose tissue is where you're producing estrone after postmenopausal, and in obese women, an increased risk of aromatase would give that problem. So in postmenopausal women, breast cancer is significantly elevated with higher levels of total and free estradiol. Again, this was serum, why I'm saying we should be testing our patients. This was done in breast cancer research treatment, and this was case controls within the Nurses Health Study. This is also a serum evaluation showing that a single blood sex hormone measurement can predict breast cancer risk for up to 16 to 20 years prior to breast cancer diagnosis. That's kind of crazy, but that's the significance that they saw. Urinary estrogen, so the dried urine or any kind of metabolites, does that have any consequence? So again, this was done in 2012. There has been a shift in what the assays are. Again, I don't know if it was 2015, but what this was showing is higher urinary estradiol and estrone, so the parent compounds, were strongly significantly associated with lower risks. Women with high urinary luteal estrone and either high or low plasma luteal estrone were a significantly lower risk of breast cancer than women with low plasma. So similar associations were observed for urinary and plasma luteal estradiol. So estrone and estradiol and the combined urinary levels, they saw a risk. Another one in estrogen metabolism, also looking at estrogen metabolites in urine. And they're saying, this was published in 2015, that serum concentrations, unless you're doing the super sensitive ones, are difficult. In the postmenopausal breast cancer studies, the association of ratios in estrogen pathways appeared independent of the recognition unconjugated estradiol. So it's also the unconjugated values that are important, and that they think that there can be some help in looking at these metabolites in the urine under the guise of breast cancer. So if we go back to Dr. Spiroff, we have to remember that he says the breast and endometrial cells are similar. Breast has alpha and beta receptors. Progesterone inhibits estradiol-induced proliferation in the breast. And also tamoxifen must be present in a concentration 1,000 times greater than estradiol. So if you've got one cell with tamoxifen and one cell with estradiol in it, who's going to win out that receptor? It's going to be estradiol. So what are some other integrative strategies that we can do for our high-risk breast cancer patients that can help them? Dietary changes. What I heard at NAMS this past week is that lifestyle changes can reduce breast cancer risk by 65%. Isn't that crazy? Why are we not talking to our patients about this? Just eating more fiber, 18% risk. Onion and garlic. I love this study because I'm Puerto Rican, but the sofrito, which has onion and garlic, daily consumption linked to 67% lower risk. Eliminate dairy, less risk. Substituting poultry for red meat, it may reduce the risk of breast cancer. So dietary changes. What about coffee? Coffee reduces breast cancer. Phew, you can keep drinking your coffee. Environmental detox, exposure to BPA. BPA is linked to breast cancer groups. So think about your skin, your makeup, your food, your cleaning product. Those should all be in a plan to eliminate those toxins. So what is my protocol for prevention? I think everyone should start with serum lab evaluations, 25, 30, whenever. I think we should identify higher risk breast cancer patients, maybe start mammograms earlier, consider MRIs. Exercise. A meta-analysis revealed that women could significantly reduce the breast cancer by 25% if they exercise regularly. And then also those dietary changes that I mentioned. And I believe everyone needs an estrogen metabolism. Maybe not even if serum levels are high, certainly if serum levels are high, but anyone that's at high risk for any kind of estrogen pathology. Like I said, family history of breast cancer, personal history of breast cancer, fibroids, endometriosis, heavy periods, all of those are the patients that you want to think about doing the dried urine test with. So in conclusion, I do believe that hormone levels do affect the risk of breast and endometrial cancer, both endogenous and exogenous. We need to do a better job of identifying our high-risk patients and those who have problems with estrogen metabolism. We should be checking estrogen metabolites on every patient that is getting hormone therapy at least once. My practice pattern is to alternate years. Serum, I do use all types of testing. I use saliva, I use urine, but I want to make sure that we're doing a urine metabolism test at least after the starting of hormone therapy, and then every couple years, if not every year. And make sure you're addressing the environmental issues and the dietary changes to your high-risk breast cancer patients. So you guys can follow me on social media, as Mark said, Hormone Guru on Instagram and TikTok. I think we should have some time for questions now. If I stop sharing my screen.
Thank you so much, Dr. Scott. We've got a few great questions in the chat, but before I get to those, I know Mark has a question that he wanted to start with, so we'll kick it over to him.
Yeah, that was fantastic. Thank you, Dr. Scott. I have like 1,000 questions just because so much interesting stuff. So I'll save most of them for some other time. But just a couple observations, I think, to affirm a couple of the things that you're saying. One, you mentioned that 2-hydroxyestrogen is pretty easy to increase, but the 4-hydroxy is hard to decrease. We just published some data in a paper of a group that was using, one of those combined products that have DIM and a bunch of other things to help your estrogen metabolism. And it showed just that the 2-hydroxy went up, the 16-hydroxy went down, and the 4-hydroxy is a wild card. In some people it goes up a little bit, in some people it goes down a little bit. So that's consistent with the data that we're seeing. And also seeing the interplay between the gut and the estrogen. Now that we have a gut marker, the indican, we're actually seeing statistically significant higher estrogen levels in both men and women that have higher indican, which indicates that something's going on in their gut, which is making it harder for them to get rid of their estrogen. So I love those observations. Here's my question for you. With breast cancer treatment, so if I have 2 women, breast cancer, one's on Arimidex, so one's on an aromatase inhibitor, so they're just shutting down the estrogen metabolism or estrogen production, and then the second one's on tamoxifen. So I want you to tell me if I've got this right and how your thinking is on this. If I take Arimidex, the lab testing mostly helps me confirm that it's working, that there's no estrogen. And if there's basically no estrogen, then the estrogen metabolism pattern isn't quite as interesting. On the tamoxifen side, I'm helping at the receptor level. So you still have estrogen, but at the receptor level, it's stopping estrogen from doing its thing, which still allows it to make a metabolite good or bad, which can damage DNA independent of what's going on at the receptor level. So then the metabolism pattern matters a little bit more. Is that how does that jive with your thinking on the value of testing and how those 2 different approaches to cancer treatment are working?
So that's exactly what I've seen because I've tested people on both. And my patients that I test on Arimidex, I mean, it seems like it is almost 100% blockage of that enzyme. It works, and you'll see very low levels of those estrogen metabolites. With the tamoxifen, but with both serum and urine, I've had patients on that. Some of it was the patient that I presented, but I've had very high serum levels, and I've called the oncologist and said, there's crazy high levels of estrogen, and they're like, oh, they're on tamoxifen, it's fine. It's you looked at I didn't have the receptor affinity of the active metabolite endoxifen, but tamoxifen is a very low receptor affinity, and I'm hazard to guess that it's not. Estrogen still wins out at the receptor, and that's why you still have women who have periods. It's not 100% blockage.
Interesting. Is there a relationship there where tamoxifen is working on the receptor, which would induce a woman to make more estrogen because if they're not getting that receptor action, or is that just women who sort of, for some other reason, have high estrogen?
So some of those, so no, I think that particular patient, and it's been more than one that I've seen with really high levels. I think it's just that they have a problem with their estrogen detoxification, which is not addressed when you're giving tamoxifen. This was exactly what you
Right.
said. When you give
Right.
Arimidex, and that's why, Arimidex, if you ask me which is going to work better, Arimidex is going to work better if you want to shut down estrogen, but people are so symptomatic on
Feel like
it.
crap. Right.
Yeah,
Right.
yeah.
So you got two channels of risk, one at the receptor, one from the metabolites, and you're only shutting down one of those to some degree with the tamoxifen. Okay. All right. I'll save my other 700 questions for some other time. Noah, let's see what everyone else has got.
Yeah, I've got a few questions that we'll jump into before we end here. Dr. Scott, would you recommend fertility hormone treatment for breast cancer survivors with endometriosis?
Would I recommend that a patient with endometriosis and breast cancer have fertility treatment? Oy, oy, oy. That's a really hard question to answer. Any fertility treatment, the goal is to increase estradiol. And the good thing about fertility treatment is that they are using micronized progesterone. They're not using a progestin. So they are using usually IM progesterone, vaginal or oral progesterone, which is going to give you that apoptosis, but you're driving those levels really high. I don't know what the standard of care now is to offer those patients to freeze eggs before they undergo treatment, for the breast cancer. But I've never even heard a traditional doctor offering that to a breast cancer patient, but it could be. That's a tricky situation. I guess it depends on your stage and your grade, and what if you've had a double mastectomy? Then you don't have any breast tissue, so that does affect it as well, and how badly you want a family.
Yeah, we talked a lot about creams and gel with estrogen and estradiol. We did have one question about testosterone pellets, and does that increase the risk of breast cancer?
So the problem with testosterone pellets, in my opinion, is in the protocols that I've seen, people are not monitoring aromatization. I don't see estrone included as on the normal labs to monitor. I see that people are checking testosterone. I don't know if they're checking even dihydrotestosterone. But I have patients who, if they have an active aromatase or if they just are getting testosterone excess, they can turn it into estrogen. So you're driving up estradiol and estrone potentially with testosterone pellets. And again, it depends on the dose. If you're not using super physiological dosing, some of the protocols I've seen is saying to drive those testosterone serum levels above 100 or 200, which are higher than our endogenous levels. So anything super physiologically is going to be, whether it's even progesterone, estrogen, anything, super physiological levels could be harmful.
Perfect. Thank you for that answer. We want to honor your time and all the time you took for us today. So that'll be the last question we get to today. So thank you all again for joining us today. Check your inboxes tomorrow for a link to the recording and to download the slides. If you have any additional questions about today's content or for general questions about the Dutch test, please email our customer support at info@dutchtest.com. And everybody have a wonderful day. Thank you again, Dr. Scott, for today's webinar.
Thank you.
Thank you, Dr. Scott.